Good evening, everyone. How are you all? Very good. Okay, so today we are going to do ECG class. Now, I'm a little bit unwell today, but because we had we had to cancel one of your class, I suppose that we will just go forward and see if we can finalize our ECG class today. Okay. So if I'm talking it in a bit low voice, just excuse me for that. So today we are going to discuss the ECG, which is a very important topic for your exam. And I hope that after today's session, you will be very good with ECG. You will have a basic knowledge on ECG reading, and that's more than enough to utilize to pass your ECG related questions in the exam. So let's start. Before you start the ECG, along with the ECG class, we will also discuss two other topics today, just by side. So one is, if you open John Murtagh 59 chapter, which is palpitation chapter, so we will go through the palpitation chapter during our discussion of the ECG. And also, if you have USMLE step to seek a book, then you will know how to get it. So if you open your emergency medicine topic, so if you open the USMLE step to seek a book, then you will see that there is internal medicine, option gynae. So if you click on internal medicine and then find out chapter 10, which is emergency medicine. So we'll be discussing the emergency medicine today as well, just related to cardiovascular system, not the whole emergency medicine, but something which is like which comes under cardiology. And many of the emergency situations are related with cardiovascular system, right? So we'll discuss these two as well during our session today. Someone's video is on, Dr. Mai Hoa. Can you please stop that uh, that that cartoon that you are using? Because in that way, people will not be able to see the slide easily. Dr. Mai Hoa, can you stop using that cartoon on your profile? Okay, let's start with the ECG session. So first of all, we need to know how the normal ECG should be looking like. So let's see that the normal ECG it has some specific parts. So if you look over here, so you can see that a normal ECG will have a P wave. So that's the P wave. And after P wave, there is a QRS complex. So you have got P wave followed by Q and then R and then S. And then there is a T wave. And then again, there will be P wave, QRS complex, and T wave. So that's how the normal ECG should go like. So first P wave, followed by QRS complex, and then T wave. Apart from this P wave, QRS complex, and T wave, there are some interval and some segment. So one of the interval which is important is called PR interval. PR interval is the starting point of the P wave and then starting point of the R wave. So that will give you PR interval. Always remember that interval includes wave, whereas segment does not include any wave. Okay? So PR interval means starting of the P wave and starting of the R wave. So that gives you PR interval. PR segment is not very important, so forget about it. Then you have QRS complex, which is important. And now you can see another thing which is very important, ST segment. So ST segment is finishing of the S wave. So this is where S wave is finished. And then starting of the T wave. That's ST segment. And then there is a T wave. And lastly, we have a QT interval, whereas the QT interval is starting of the Q wave, okay, and end of T wave. So that's QT interval. So if we look on this side, we can see that PR interval is starting of the P wave and then starting of the R wave, that's PR interval, finishing of the S wave and starting of the T wave, that's ST segment, and starting of the Q wave and finishing of the T wave, that's QT interval. Are you guys understanding these normal structures of the ECG? So what is P wave, what is PR interval, QRS complex, ST segment, QT interval? So are you getting an idea about this? Everyone clear about this normal structure? Any confusion? Perfect. Now, if we look over here, that your ECG is divided into like some large square. So you can see that this is one large square, how it looks like. And within one large square, it has 5 small squares. Like this. So it is not it is not given in this picture, but this is how it is. So one large square, and in between one large square, you have got 5 small squares. Now there is a lot of, like I can discuss just the normal ECG in 1 hour, but that's not important for your exam. So important is to understand the basic of it, and that's what I'm going to follow. Okay, so we don't need to know like 1 square equal to 0.04 second. So this discussion is not what we are going to discuss today. So I will discuss the things that you can remember. Okay, so first of all, every wave segment and interval that you can see has some normal space. So we say that PR interval, so this is your PR interval, this one and this one, right? A PR interval ideally should be 3 to 5 small square. Now in here we have like this picture is for like they have made it bigger for you to understand, but this is not the normal one. So PR interval should be between 3 to 5 small square. Normal QRS complex, so this complex is between 2 to 3 small square. And then QT interval that you see in here, that's 8 to 11 small square. All you need to do is to remember this normal value of this interval and segments. So PR interval, the normal PR interval is up to 3 to 5 small square, QRS 2 to 3 small square, and QT interval 8 to 11 small square. Okay, so now that you know the normal value, we will move on to the next thing. Calculating the heart rate. How we can calculate heart rate from the ECG. This doesn't come in exam, but it's not a bad idea to know because you are learning ECG. You should know how to calculate heart rate. So To check the heart rate, first of all, you need to know that if the rhythm is regular or irregular. If the rhythm is regular, then count the number of large square between two RR interval and then divide it by 300. So something like this, because there are 300 large square per minute and you're checking the heart rate per minute. Okay. So what we normally do to check the heart rate, so this is one R, this is another R, this is another R. First, check if the rhythm is regular or irregular. Regular rhythm means every RR interval is equally spaced. So we can see that there is one large square, two large square, 3 and 4 large square. And again in here, 1, 2, 3, 4. So they are equally spaced. That means this is a regular rhythm. When rhythm is regular, heart rate is calculated as 300 divided by number of large square in between two RR interval. So this is one and this is one RR interval. So in between this RR interval, there are 4 large square. So you divide 4. So 300 divided by 4 equal to 75. That's the heart rate. Okay. So from where the 300 came? Because there are 30 large square in 1 minute. Okay. So that's why we are adding 300. If you want to check, if you want to do with the small square, then heart rate is calculated as 1500 divided by number of small square you have got in between two RR interval, which is hard and a little bit complex. So that's why we don't bother about it. So it's just very easy. If rhythm is regular, then you just calculate how many large square is there in between two RR interval and then just divide it. So 300 divided by 4. Okay. So that's how we calculate the heart rate if rhythm is regular. If the rhythm is irregular, which you can find in atrial fibrillation, then you calculate the number of number of R wave or QRS complex in 30 large square and multiply by 10. So it is not needed at all. So just you can remember it. So you'll need to find out how many QRS complex is there in 30 large square and then multiply by 10. Okay, that will give you the heart rate. So that's how we calculate the heart rate from a ECG. Not very important for you. Now, going to the conditions and disease from where the question will come in exam. So first we are going to discuss about supraventricular tachycardia. So supraventricular tachycardia means when the arrhythmia starts from the upper layer of your upper chamber of your heart. So supraventricular, which means when the arrhythmia, the origin of arrhythmia is above the ventricle, which means in the atrium. So in supraventricular tachycardia, all of this arrhythmia patient will present to you with palpitation, feeling a bit dizzy, lightheadedness. So that's the main presentation. And then you do the ECG. In the SVT, the ECG will look something like this. So let's see how we can read SVT ECG. So in the SVT, what happens is that there will be no P wave. Okay, so no P wave. QRS complex will be narrow. The rhythm will be regular. And definitely there will be tachycardia. So if you check over here, you can see that every RR interval are equally spaced. So rhythm regular. And if you check the heart rate, it's definitely increased, right? So if we like 300 divided by how many large square is there? 1 and a bit, like you can say 1.5 large square, right? So even if we just put 1, it becomes 300. So this is probably between 200 to 250. So that will be the heart rate in here. So which means that there is tachycardia, which is what's in here. So supraventricular tachycardia. So patient will definitely have a tachycardia. Rhythm regular. Now, if you look over here, the QRS complex. you can only see one small square, right? So if you see over here, there is only barely there is one small square. So we know that QRS complex is usually 2 to 3 small square, but this has got one. So that's what we call as narrow complex tachycardia or narrow QRS complex. And if we look over here, the after QRS complex, there will be T wave. So this is T wave. But after T wave, there is no P wave. So there is lack of P wave as we see. So no P wave, narrow QRS complex, and regular rhythm with tachycardia. That's SVT or supraventricular tachycardia. Okay. Clear, everyone? Any query about this SVT? And if you go to John Murtagh, there is a bit of discussion about supraventricular tachycardia, which I would like you guys to read by yourself. But I have discussed about the management of SVT in our cardiology question solve class, if you guys can remember. Do you guys remember, like we discussed about SVT and atrial fibrillation management? So this is where you can read about the SVT. So there are lots of types of SVT, but paroxysmal SVT is common. And sometimes even in a young, healthy patient, this can be there. So you can get SVT even in a healthy patient. Look for features of thyrotoxicosis because that sometimes can be an underlying cause of this. Management of SVT. In management of SVT, first thing is we check that if the patient is stable or unstable. If the patient is stable means that, like let's say unstable means that patient having hypotension, having altered mental status, then patient is also having chest pain, severe shortness of breath, features of cardiac failure. Okay, so especially if the patient is having hypotension, along with that altered mental status, that patient is unstable. For unstable SVT, you will need to go for DC cardioversion. Okay, so DC cardioversion is the treatment if a patient is unstable. But if the patient is stable, then you can start with some vagal stimulation. So vagal stimulation, it can be done by carotid sinus massage, but nowadays we don't do carotid sinus massage too much because it can sometimes cause a stroke. So carotid sinus massage is no longer our treatment of choice for vagal stimulation. Rather, nowadays we do Valsalva maneuver. That's the common one. Then in self-induced vomiting, cold or ice water to face or swallowing of ice, immersion of the face in water. So any of these can stimulate the vagal nerve. So we can try any of them. Let's say vagal stimulation is failed, then the treatment will be IV adenosine. If IV adenosine, you can try 3 times. So first 6 milligram, then 12 milligram, then 18 milligram. Even after trying that patient is still in SVT, the second line option could be either a beta blocker or a calcium channel blocker. So metoprolol or verapamil. Okay. Even after that, still patient is in SVT, then you will need to go for cardioversion. Okay. To prevent recurrence, so if a patient having frequent SVT, you can prevent the recurrence by using any of these. So any of the beta blocker like atenolol, metoprolol can be used. If they say that patient getting frequent attack and it not responding to medical therapy, the curative option for SVT is radiofrequency ablation of the arrhythmic point. So from where the arrhythmia is originating, you can do ablation of that area and that can cure the condition. Okay, so that's That's actually the management for SVT. If it is a well-controlled asthma, then no problem. But if it is an uncontrolled asthma patient, then yes, we can't use adenosine for that patient because it can make it worse. So for them, you can try a calcium channel blocker. Moving on to atrial flutter and atrial fibrillation. So first, atrial flutter. Atrial flutter, there are two presentations of it, and all of this, the patient will have tachycardia or heart rate will be elevated. Patient will have palpitations. That's the main feature. So if you look over here, atrial flutter, most of the time, they can have a regular rhythm. So rhythm is regular, right? But it's not always. They can have irregular rhythm, even in flutter. So regular rhythm, and the P wave will be replaced by some sawtooth wave. So the sawtooth looks like this. So you can see the, so these are all P waves. Now the atrial flutter will only have regular rhythm if there is constant P wave versus QRS complex. What do I mean by it? We say this thing, like if you see there are 4 P wave, 1, 2, 3, 4, and then there is one QRS complex, so 4 by 1. And this 4 by 1, it's been the whole ECG having the same constant block. So 4 by 1, right? So when a patient has got the constant block like this, then the flutter will have regular rhythm. But let's say someone having different kind of block. Like if we go to the next page, you can see that. So atrial flutter with variable block. In variable block, you can see that this is still atrial flutter because the patient has got sawtooth wave pattern, right? But you can see that it's not regular. There is irregular rhythm here. The reason is that this one has got 2 by 1 block, whereas this one has got 1, 2, 3, 4, 4 by 1 block. This one has got 3 by 1 block. So when there is a variable block like this, then flutter can also have irregular rhythm. So many candidates, they just know that atrial flutter will always have regular rhythm, and if it is irregular rhythm, it will always be atrial fibrillation. So it is not like that. It depends on if it is a constant block or variable block. So the only way to recognize your atrial flutter is by looking at the sawtooth wave pattern. If you get the sawtooth wave pattern, then it is atrial flutter. Making sense for everyone? Great. Moving on to atrial fibrillation. Now, fibrillation will always have irregular rhythm. So you can see how irregular it is, right? There will be absence of P wave. So P wave will be replaced by some fibrillatory F waves. So what happens in atrial fibrillation, that rather than having a single P wave like this, they will have like this. So kind of a fibrillation or like a kind of a wavy pattern, but it will not be sawtooth like this, but kind of a wavy pattern will be there. So you can see the wavy pattern over here. So that wavy pattern is called fibrillatory wave. So if you have got a patient who is coming to you with palpitation, and then you have got irregular rhythm, their pulse might be elevated, might be normal. Sometimes there might be just a normal pulse in atrial fibrillation patient. And then also you have got this fibrillatory wave with no P wave. That's atrial fibrillation. Okay. Now, in your exam, they will not just give you one ECG or one wave like this. They will give you the full ECG, and then you will need to find it out. So when they give you full ECG like this, then it becomes a bit hard, right? So what you look at is that you look at the presentation. So if patient presents to you with palpitation, you always look at the long lead. So a long lead means the lead where you can see all of the, like, you can see that this one has full lead. So let's say that you have got a long lead over here. They have given 3 long lead, but usually they just give 1 long lead in the exam. So you look at the long lead in an arrhythmia patient, and then you decide what's the condition having in this patient. So if we look over here, this is very hard to get, but let's say we're looking over there. We can see that the rhythm is definitely irregular, right? So irregular rhythm. Can we see any sawtooth pattern in here? We can't. So most likely it is atrial fibrillation. Try to find any fibrillatory wave. So if you are very vigilant, you can see that there is a bit of fibrillation in here, bit here, definitely in here. So it's very hard sometimes to get it, but you will just need to use your logic in the exam. That if it is irregular rhythm, then either it is a flutter or fibrillation. Have I got any sawtooth wave pattern? No. So it is most likely fibrillation. Now, management of atrial fibrillation is very, very important for the exam. We discussed that in our question solve class, but we'll just recapitulate it. So go through this atrial fibrillation from John Murtagh, read it by yourself. But definitely remember that atrial fibrillation, one of the most common cause is myocardial infarction. So look for underlying cause, MI, pyrotoxicosis, hypertension, diabetes, cardiomyopathy, these all can cause AF. All patients who has AF should have their thyroid function and the echocardiogram to find out any cause. So fibrillation and flutter, the treatment is same. What we normally look for this, that if a patient has got atrial flutter or fibrillation, is this patient stable or unstable? So if the patient is stable, then we try rate control. Okay, so rate control is you want to lower down the heart rate for this patient. So rate control, normally we give beta blocker. So you can use metoprolol, atenolol, any of the beta blocker or calcium channel blocker. So you can try a rate control medication. If rate control doesn't work and patient is still having the symptom, then you go to the next step, which is rhythm control. The rhythm control can be done by antiarrhythmic medication, which can be either amiodarone or flecainide. Okay. Now, even after amiodarone or flecainide, if the patient is still having the AF, your last option will be synchronized DC cardioversion. So a step-by-step approach. So first rate control with beta blocker or calcium channel blocker, then rhythm control by amiodarone or flecainide, and then synchronized DC cardioversion. For an unstable patient, DC cardioversion will be your first line choice. Now, there is also another option that if patient is getting frequent AF or having a permanent AF, so every time you check their ECG, they are always in AF, you have tried medication, it's not working. So if the rate cannot be controlled despite maximal medical treatment, then you can go for AV nodal ablation and a permanent pacemaker for that patient. Okay, so that's the definitive treatment, and that's the last resort for this patient. But step by step is rate control, rhythm control, DC cardioversion, and the last is AV nodal ablation and pacemaker. So that's what you need to remember in your head. Okay. Every patient who has atrial flutter or fibrillation We need to also think if that patient has any high risk of developing atrial fibrillation related clot or embolism. So most of these patients, they are high risk of developing a embolism because AF patient, they have more tendency to form clot in their heart. And one of the clot can dislodge and that can travel to the brain causing a stroke, that can travel to the superior mesenteric artery causing a mesenteric ischemia, that can travel to the leg arteries causing an acute vascular ischemia. So that's the reason why AF patient needs to be assessed to know that if they are high risk of thrombosis. How we do this? We follow this CHATS-VASc score. In the CHATS-VASc score, you can see the scoring: C for congestive cardiac failure, H for hypertension, Age above 75 will get 2 points, diabetes, stroke or TIA 2 points, any vascular disease like PVD 1 point, age between 65 to 74 1 point, and female 1 point. Okay, so that's the CHATS-VASc score which you need to remember and you need to utilize if they're asking for anticoagulation in this case. So how we do it is that we go to the JAM. For everyone who has a CHATS score, if a male having a score of 0 and women whose score is up to 1 do not require anticoagulation. So if the CHATS-VASc score is 0 in a male and up to 1 in a female, they will not require anticoagulation. In male, if the score is above 2 and female above 3, they are definitely going to have anticoagulations. What if between that? So what if a male patient has got 1 or a female patient has got 2? So those are gray area. For gray area, it is usually better to get a cardiology review to decide if they will require any anticoagulation or not. If cardiology review is not in the option, then you will start with anticoagulation even for this group. So only patient who will not require anticoagulation is a male with a score of 0, female with a score of up to 1. And other than that, everyone will require a anticoagulation. What kind of anticoagulation? Nowadays, we use the direct acting oral anticoagulant, which is the DOAC. And before we start DOAC, we always need to make sure patient has a good kidney function. So if their kidney function is good, you can use any of the DOAC, which means apixaban, rivaroxaban, or dabigatran. We no longer use warfarin in atrial fibrillation anticoagulation management unless the patient having a prosthetic heart valve. So those with valvular AF, that means someone who has got, let's say, valvular heart disease, with that, they have got atrial fibrillation, or they are having a mechanical heart valve with AF. So any valvular AF, that patient will require warfarin for anticoagulation. Apart from that, everyone else will get DOACs. Okay? No longer we use aspirin, clopidogrel, or ticagrelor for AF patient. Clear everyone about this management? Digoxin is no longer our first line option. So digoxin is only time we will use digoxin in an AF patient if a patient has got AF with heart failure, okay, and the heart failure. So AF with heart failure, which is like decompensated heart failure, where you can't use beta blocker, that's the time we use digoxin. So AF with a decompensated heart failure, where we can't use the beta blocker, that's the time we use digoxin. Otherwise, we don't use digoxin anymore. Very rarely we will use it. And Dr. Mehra, yes, GFR, if the GFR is less than 30, then yes, you're going to use warfarin. Why age came twice? There is different age. One is age above 75, they are high risk, gets 2 points. And age between 65 to 74, they are high risk, but not that high risk like 75. So if kidney function is not good, then warfarin is the choice. Not really, Dr. Darwin. So Chats-Vasquez score has to be used for any AF patient, either valvular or non-valvular, because you need to first decide if that patient require anticoagulation or not. Okay, once you decide, yes, this patient require anticoagulation, then you think that this is a valvular AF or non-valvular AF. And what is CD versus digoxin? What's the CD, Dr. Ahmad? And if AF patient rate is well controlled, do we go for anticoagulation or rhythm control? Depends on the symptom. If the patient with AF having normal heart rate and they're not symptomatic, okay? If they're not symptomatic, then no need of giving the rhythm control medication. If they're symptomatic, like feeling palpitation, dizziness because of this, then you will go for rhythm control. And warfarin indication, Dr. Niranjan, is only time if a patient has got valvular AF. So if a patient has got mitral stenosis, which is a valvular disease, or if a patient has got prosthetic heart valve, like new heart valve, then this patient will require warfarin. And the target INR for using warfarin is 2 to 3 for like, let's say, mitral stenosis, just valvular heart disease, then 2 to 3. But for prosthetic heart valve, it is 2.5 to 3.5. And usually rate control is our first choice, Dr. Aftab. So rate control is our first choice. We don't go directly to rhythm control unless we need it. So rate control will be the first line. If heart rate is normal, then you can think of rhythm control if patient is symptomatic. Yes, anticoagulations and rhythm control, definitely you can use together. It's different purpose. So your rate and rhythm control is for treating atrial fibrillation. And anticoagulation is to make sure patient doesn't get a complication from AF. So different management. Yes, so sometimes if we are going for a DC cardioversion, some of the AF patient will require a elective DC cardioversion. So in elective DC cardioversion, it is ideal to have a 4 weeks of anticoagulation before you go for DC cardioversion. Okay, but if someone requires emergency DC cardioversion, there is nothing you can do about it. You'll just need to go for it. Target heart rate control is below 90 if we can do it. 110, it is still high, so it is tachycardia, so you'll need to use rate control medication. Moving on to ventricular tachycardia. So ventricular tachycardia and ventricular fibrillation, this is also very important for exam. So if we look over here, in ventricular tachycardia, there are 2 types of ventricular tachycardia you can get. One, monomorphic VT or polymorphic VT. Monomorphic means where QRS complex looks same in size and shape, like this one. And polymorphic VT, there are different sizes and shape. In ventricular tachycardia, definitely you can see the QRS complex is very wide, right? So you can see each of the QRS complex is widened. So wide QRS complex, but their rhythm will be regular. So if we look over here, you can see that all of them are equally spaced, right? Or you can just measure in this way. So regular rhythm, wide QRS complex, and definitely you can't see any P wave in here. So no P wave, wide QRS complex, regular rhythm, that's VT. Whereas polymorphic VT, they will still have regular rhythm. You can see that they might be of different size and shape, but the rhythm is regular. Okay, so rhythm regular, wide QRS complex. So this QRS, obviously it is more than 3 small square, right? So wide QRS complex, and you can't see any P wave. So that's the time you would think of ventricular tachycardia. Now, ventricular tachycardia management depends on two factors. One, that does the patient has pulse or not? So VT with pulse and VT without pulse has a different kind of management. So if the patient has VT with pulse, if it is an unstable patient, that patient will again go for a direct DC cardioversion. So unstable patient, DC cardioversion is the first line. If it is a stable patient, then there are a few options that we have got. For a stable patient with VT, if we go to our emergency medicine chapter, so that's VT. So a stable VT without serious hemodynamic compromise can be treated medically with adenosine initially, and then antiarrhythmics if no response. So you can use adenosine initially if the patient having a monomorphic VT. So the adenosine only can be used if it is a monomorphic VT, not polymorphic VT. So for monomorphic VT, patient is stable, adenosine. If that's not helping, then you can go for antiarrhythmics. So the common antiarrhythmic that we use is procainamide or sotalol. Even after procainamide or sotalol, there is no response, then amiodarone can be tried. Okay, so a step-by-step approach is adenosine, procainamide or sotalol, amiodarone, followed by lidocaine, and finally electric cardioversion. So that's the step-by-step approach. Okay, so we say that if it is a stable VT, then we can try adenosine, procainamide or sotalol. If that is not helping, then amiodarone, and then lidocaine, and then electrical cardioversion. Okay, so that will be the treatment of VT with pulse. And VT without pulse will require defibrillation. So this is a non-synchronized cardioversion. So because the patient who doesn't have pulse, so the treatment will be same like a ventricular fibrillation. So ventricular fibrillation and VT without pulse, the treatment is same. So the treatment is defib, shock. So you have to shock the patient immediately. There is a subtype of polymorphic VT, which is what we call as torsa di pointa. So torsa di pointa means that it's a part of a polymorphic VT, but the VT will look like that it is kind of a wear, or it will be carving around each other. So can you see the curve like this? So when there is a curve like this, then you will be using the term called torsa di pointa. Okay, this is clear for everyone, like the torsade pointer? And some of you are asking about polymorphic and monomorphic VT. So monomorphic means you can see that all of them are equal size and shape. That's monomorphic. And polymorphic, you can see different sizes and shape, right? That's called polymorphic. So is torsade pointer is understandable for everyone? Okay. So you've got the idea between monomorphic and polymorphic VT. Is it necessary to perform echo before DC cardioversion? All AF patient will have a echocardiogram. So yes, we do echocardiogram before the DC cardioversion, but that's for elective DC cardioversion. For someone who is having like emergency DC cardioversion, you don't have any time to do anything. And as part of the emergency medicine guideline, so amiodarone is not our first line option. Okay, because amiodarone is our last resort of antiarrhythmic. So you can definitely try, rather than procainamide, sotalol is commonly used in Australia. So you will try sotalol first, and then if it is not helpful, then you can go to amiodarone. So torsade pointer, most of the time they have some underlying cause. So I would like you to read a little bit more about torsade pointer from the Google. So you can go to life in the first lane. So if you still need some help to understand the ECG, life in the first lane. So LITFL, if you search any kind of ECG from life in the first lane, then you will get a very good idea about some of this topic that we are discussing today. Okay. Now, I would like you to go through the LITFL guideline for torsade pointer about the underlying causes, because there are lots of causes behind this torsade pointer, especially the condition which causes prolonged QT interval that can also cause torsade pointer. So let's say that if a patient has got intercurrent infection at the moment, infection can cause torsa. If a patient having electrolyte abnormality like hypokalemia, hypomagnesemia, so any hypoelectrolyte can cause torsa. If a patient is on some antibiotics such as erythromycin, that can cause it. If a patient on antiarrhythmic medication like amiodarone, sotalol, that can cause it. Okay, so torsade pointer, the first thing is to find out the cause behind it, if there is anything causing it, and then stop that medication if you can. So what will be the management of torsade pointer? This is a bit tricky, so many candidates forget about it in the exam. If a patient with torsade pointer is stable, then the management is magnesium. That's our first line treatment. If magnesium failed to treat the torsa, then you can try either isoprotenolol or lidocaine. Okay. If it's still not helpful, then you can go for overdrive pacing or cardioversion. Okay. So magnesium is the first line. If magnesium doesn't help, then isoprotenolol or lidocaine is the treatment. Dose is not required for exam. So Dr. Faria, it doesn't come in exam, so we don't discuss dose. Synchronized and unsynchronized DC cardioversion. So we discussed that in our class, but again, we can discuss. So Synchronized DC cardioversion is when you give shock to a patient aligning with the R wave. So you look at the ECG, like ECG monitor, and you will be giving the shock when R wave is there. So when R wave is on the ECG paper, then you give shock. So you synchronize with R wave. That's why it is called synchronized cardioversion. And in ventricular fibrillation, because it's just chaos like this, you can't see any R wave. So you will just give shock at any time. That's why it is unsynchronized. Now, ventricular fibrillation, it is a chaos, like a chaotic rhythm in heart, right? And it is the worst thing to get because VF can cause sudden death. So it will be extremely irregular heart rhythm. Heart rate can even go up to 600. E wave will be absent. So everything is absent. All you will see is like fibrillatory wave. So this is how it will look like. So you can see the chaos on the ECG, right? So when you see something like that, you know what's going on. So you can see that the rhythm is definitely irregular and you can't see anything else apart from just QRS complex, which is all over the place. Okay. So when you see something like that, that is ventricular fibrillation. And for ventricular fibrillation, the treatment is defibrillation, which means you'll need to give shock. Now, coming to some management, which is part of your advanced life support, part of emergency medicine. That's right, Dr. Nahid. For monomorphic adenosine can be used as first line. For polymorphic, we will use sotalol rather than procainamide. So any of these can be used, either procainamide or sotalol, but we prefer sotalol. Okay, so let's say you have got a patient who doesn't have any pulse, right? So patient suddenly collapses and you are checking the pulse, you can't see pulse, you can feel the pulse. When you can't feel the pulse, what is your immediate action? Your immediate action is call for help and start CPR. So while you are using 30 by 2 cycle of CPR, so 30 compression followed by 2 breath, you will also, if someone is there, while you are giving the CPR, they can attach the ECG monitor or defibrillator monitor. So they attach the monitor and then you check the rhythm. Is it a shockable rhythm or not? So shockable rhythm are VF or VT. So if the patient having VF or VT, you can shock that patient. If the patient has asystole or pulseless electrical activity, I will discuss what that means. If they have this, this is not shockable rhythm. So let's say we have got a shockable rhythm. Then while you are continuing the CPR and you stop the CPR and you give the first shock. Okay. Immediately after finishing the first shock, you start the CPR. So you continue the CPR and you finish 5 cycle of CPR. So 5 cycle of 30 by 2 breath. So you finish the 5 cycle of CPR, you again check the rhythm. Is the patient still in shockable rhythm? If the patient is still shockable rhythm, then you give second shock. While you are giving the second shock, now this time you can also give epinephrine to the patient. So after the second shock, you can give epinephrine or adrenaline. You will definitely resume the CPR immediately after the shock. You give 5 cycle of CPR. Then again check the rhythm. This is the third time. So still patient is in VF or VT. So it's shockable. Then you give the third shock. Resume the CPR immediately. And this time you can give amiodarone or lidocaine. Okay. So this is what we normally use for shockable rhythm, which is VT or VF. So first CPR, check the rhythm if it is shockable or non-shockable. If it's shockable, then give first shock, resume the CPR, check the rhythm again, second shock with epinephrine, followed by third shock with amiodarone. That's all that you need to remember. Okay. If it is a asystole or PEA, then you will continue the CPR because you can't shock the patient, but you can give epinephrine to this patient. So you can give epinephrine and you can repeat it every 3 to 5 minutes. After finishing the 5 cycle of CPR, you again check the rhythm to see that if now after giving epinephrine, it is shockable or not. If it is shockable, then you go to this shock part. So then you start giving shock and one by one you follow this step. And if it is still not shockable, then again you start giving epinephrine and follow the pattern. Okay. So this is how we manage manage as a advanced life support, like a ALS, in a patient who has collapse and we can't feel their pulse. Now, what is asystole? Asystole means you can see there is nothing going on. So you can't even see any electrical activity on the heart. So complete absence of electrical activity in the heart is asystole. And then there is pulseless electrical activity. It is hypotension to the point of losing one's pulse, but there is still a bit of electrical activity on the ECG. So I can show you the pulseless electrical activity ECG, but in pulseless electrical activity, you will get a little bit of electrical activity, but you can't feel the pulse. Okay. So if you have got a patient who has got asystole or pulseless electrical activity, that patient will require CPR followed by epinephrine. Okay. So that's a bit of idea. Now you don't need to go into too much detail about this because it's not needed for your exam, but you need to have a basic idea about this thing. How to differentiate a polymorphic VT and VF. VF will have irregular rhythm. So rhythm will be all over the place. So if you check the rhythm in here, you will be able to find it out. Okay, see that there are, let's say that there is 3 small square. And now if you look over here, there's definitely 5 small square, right? Same. So you can definitely find out that the rhythm is not regular. When rhythm is not regular, that's VF. And in polymorphic VT, still there will be regular rhythm. That's how we differentiate. Moving on to WPW syndrome. So we discussed a little bit about WPW syndrome, how this works, right? So in WPW syndrome, patient will have an accessory pathway which will bypass the AV node. So we know that our electrical impulse start from the SA node, goes to the AV node, and then it goes to our whole hearts by bundle of His and Purkinje fibers. So your AV node is here. So if someone has got a lot of arrhythmic events going on the atrium, AV node is supposed to delay that so that all the electrical impulses doesn't transmit to the ventricle. So in that way, AV node can at least help your heart to get into like arrhythmia. But there is a condition called WPW syndrome where there might be an accessory pathway which can bypass this AV node. So what will happen that all the arrhythmia which is starting in the atrium, it can go directly to the ventricle. So that's why these patients can have a severe tachycardia. Apart from that, the best way to find this WPW syndrome on the ECG is to get the delta wave. So if we look over here, what you see is called delta wave. A normal QRS complex will be a straight, but delta wave will be like kind of a upslaring. So see the upslaring over here? So this upslaring is what we call as delta wave. Okay? If you get this kind of upslaring or bit of tilted QRS complex, that's delta wave. And that is normally what will give you the diagnosis. Apart from that, you can get a bit of other finding like PR interval can be less than 3 small square, which is very hard to get. QRS can be a little bit prolonged. Again, it is hard to get, but delta wave is the one which will help you to diagnose. So if you get a patient with this delta wave on ECG, what will be the treatment? As I said in our question solve class, that this is a condition where you can't give any conventional heart rate lowering medication, because most of the heart rate lowering medication work by delaying the AV node. So if you give some medication which delay the AV node more or which blocks the AV node more, that's not going to help. So we need to give something which does not affect AV node at all. So you can't give beta blocker, calcium channel blocker, adenosine, or digoxin in a patient with WPW syndrome. The only medication that can be given is amiodarone or any other antiarrhythmics. Okay. That's for a stable WPW syndrome. If it is an unstable patient, the treatment will be same like SVT, which is DC cardioversion. Okay, so we'll take a 10-minute break now while you can think about what we have discussed, and then we will start with the heart block. We still have myocardial infarction, ischemic heart disease, some of the very important ECG still left. So we will discuss that after the break. Okay. Thank you, everyone. 10-minute break. All right, everyone, let's start again. Okay, so now we are discussing heart block. So there are three kinds of heart block: first degree, second degree, and third degree heart block. So first of all, first degree heart block. So in first degree heart block, what happens is that patient will have a prolonged PR interval. That's why PR interval is important, because in first degree heart block, all you get is that your PR interval will be longer than 5 small square. So if you see here, so this is P and that is R, right? So this is your PR interval, and definitely it is 10 small square, but it should be up to 5. So PR interval has got increased. Same this one, PR interval has increased. Okay, but you can see that after every P wave, there is a QRS complex. After P wave, there is a QRS complex, right? So there is no drop bit. When there is a drop bit, it becomes second degree heart block. But in first degree heart block, there is no drop bit. Only thing that you get is your PR interval will be increased. That's the only finding. And patient with heart block, they mainly present to you with feeling dizzy or maybe had a syncopal attack, something like that. Have a look on second degree heart block. So this is the main one which confuses a lot of candidates. Second degree heart block has two types. One is Mobitz type 1 and another is Mobitz type 2. So in Mobitz type 1, so a patient will have progressively increasing PR interval until there is a drop bit. So PR interval, each time it will be increased. And at some point, there will be a drop bit. So if we look over here, you can see that this is the PR interval. And then definitely the next one has got increased. The next one has got more increased. And then there is T wave. Then this is the P wave. After P wave, there is no QRS complex. So there is the drop bit. Okay, so when progressively PR interval gets increased, but at some point there is a drop bit, that is what we call as Mobitz type 1 second degree heart block. So what is Mobitz type 2? Mobitz type 2 has constant PR interval, and at some point there is a drop bit. So the difference between Mobitz type 1 and 2 is that Mobitz type 1 will have progressively increasing PR interval and then there is a drop bit, whereas Mobitz type 2 will have a constant PR interval and at some point there will be a drop bit. Like if we see over here, this is the PR interval and then this is another PR interval. So it is not increased. So it's constant, right? And then there is a P wave, but after that there is no QRS complex. So that's the drop bit. So constant PR interval followed by a drop bit, that's Mobitz type 2. Up to this, everyone clear that what is like first degree heart block, what is second degree heart block? Everyone clear? Okay, very good. The problem and the most confusing heart block is complete heart block or third degree heart block. So third degree heart block is there will be no relationship between P wave and QRS complex. So P wave and QRS complex will be independent of each other. And the only thing that will be regular is PP and RR intervals. So this patient will have a regular RR interval. So if you see that this is the R, so they are regular, right? So regular RR interval, but P wave will not be followed by QRS complex. So they will be just acting like they are different from each other. Like a normal ECG has P wave, then it will be followed by a QRS complex, right? But in complete heart block, if we look over here, this is the P wave. After that, there is no QRS complex. Then there is a P wave. Now that becomes the confusion part. after POF there is a QRS complex. Okay, so it means that sometimes there will be a little bit of like they will be acting together, but most of the time you will see that they're not acting together. So this POF, no QRS complex. Then there is another POF, no QRS complex. This POF, you can see that there is a huge gap in here. So this is also not following the QRS. Then another POF, no QRS complex. So every time you're seeing that there is some independent POF. Okay, and that is what you get in a complete heart block when POF and QRS complex is not dependent on each other, or they're independent, they are not following each other. That's what we call as complete heart block. If we look on this ECG, you can see that the RR interval is regular, right? Now, if we look over here, this is the T wave, then there is a P wave over here. There is no QRS complex, right? There is QRS, but there is no P wave. So QRS is also independent. This is a P wave. There is no QRS, but it is a bit distant from the P wave. There should be another P wave here, which is we can't even see it. In here, there is a P wave which is not following any QRS. There is another P wave here, which is a bit distant from the next QRS. This P wave not following any QRS. This P wave not following any QRS. This P wave not following any QRS. So you can understand the pattern, right? So you have to see multiple one to get an idea. Don't just get confused by looking at one point. So when you look at multiple point in the long lead, it will give you a pattern that RR interval regular, but most of the P wave is not followed by a QRS complex. That's the time you can say that this might be a case of third-degree heart block. Okay. So what is the treatment? It depends on the symptom. So first degree and Mobitz type 1 second degree, there is no specific treatment if patient is asymptomatic. All we need to do in first degree and type 1 second degree heart block is to stop any offending drug. Like if a patient is on digoxin, if a patient is on beta blocker or calcium channel blocker, we will stop that medication because it can reduce the heart rate even further. If patient is symptomatic, then you can use atropine in this patient. Okay, so first degree and second degree type 1, no treatment until patient is asymptomatic. Stop the offending drug. If symptomatic, then atropine. Whereas Mobitz type 2 and third degree heart block, there will be treatment even if patient is asymptomatic. So first treatment is always to stop any offending drug. And then Mobitz type 2 and third degree heart block will need a pacemaker, even if they are asymptomatic, which most of the time they will not be. They will be symptomatic. So for that patient, you'll need to have a pacemaker. And pacemaker, especially if it is a third degree heart block, patient can become unstable. So in an acute third degree heart block, you can even just go for a transcutaneous temporary pacemaker. Whereas if it is a chronic stable third degree heart block, then patient will go for a permanent pacemaker. So that's usually the treatment. So type 2 and third degree will need treatment with pacemaker, and first degree with second degree type 1, just if asymptomatic, no treatment rather than stopping the medication. No need of aspirin in heart block. There is no role of it, but atropine. So atropine can be used. So in any of these heart block patients, they are symptomatic, you can use atropine, even in third degree or Mobitz type 2. Now we are moving on to bundle branch block. It's not important. They would not ask you diagnosis of bundle branch block, but it's a good idea to know. So there are two kinds of bundle branch block. One is right bundle branch and another is left bundle branch block. So RBBB and LBBB. So in RBBB, we look at the V1 and V6. So V1 to V6 are your chest lead. So in the chest lead, if in V1, V2, V3, you have got a M pattern. So see the M pattern over here. So if on V1, V2, V3, you get a M pattern, and in V5, V6, you get a W pattern like this, that's what we call as RBBB. So M pattern in V1, V2, V3, and then there is a W pattern in V5, V6, that's called right bundle branch block. Right bundle branch block is mainly found in any kind of right heart problem. So if someone has got right ventricular hypertrophy, pulmonary embolism, if patient has got pulmonary hypertension, so anything related to right heart can give you right bundle branch block. Right bundle branch block is not something that much significant, but the significant one is LBBB, or left bundle branch block. Left bundle branch block, it's important given that sometimes a new onset of LBBB can be an indication of an acute myocardial infarction. So that's why getting the LBBB is important to know. So LBBB is totally opposite of RBBB. So you will get M pattern in V5, V6. So you can see that M pattern over here. So if you get M pattern in V5, V6 and W pattern in V1, V2, V3, that's LBBB. I don't even bother about this. I just remember one thing. So in RBBB, I will get M pattern in V1 to V3. And in LBBB, I will get M pattern in V5, V6. That's the only thing I will remember, nothing else. Because getting W pattern is hard, but M pattern is very easy to know or easy to detect. Okay? So just remember that if you get something like that, then you'll know what it is. Don't get confused about this M pattern. So causes of LBBB is anything related to left heart. So aortic stenosis, ischemic heart disease, hypertension, dilated cardiomyopathy, myocardial infarction, all can cause LBBB. That's why it is important. And there should be both M and W. So M will be in V1 to V3 and W in other pattern. Okay, so most of the time they will be together. But you can just remember one thing. So if it is RBBB, there will be M pattern on V1 to V3. If it is LBBB, then M pattern on V1 to V6. That's easier to remember. Moving on to myocardial ischemia, which is very important for the exam. Now I am moving a little bit faster because we still have a lot of things to discuss. I don't want to discuss things that is not important for the exam, like what is the difference between transvenous and transcutaneous pacemaker, which is just for a cardiologist, which is not for your preparation. So let's not go into that direction. So stick to what is really needed for AMC. So myocardial ischemia or myocardial infarction is the most important topic for ECG in exam. And if you miss this kind of ECG, the software doesn't like it. So it means that you have missed a mastery question. So myocardial ischemia, it includes non-ST elevated MI or non-ST elevated non-ST elevated acute coronary syndrome, and then there is ST elevated MI. So non-ST elevated acute coronary syndrome has two types. One is unstable angina and non-ST elevated MI. All of you know that. There are two main ECG patterns for a non-ST elevated ACS. One is ST depression, another is T-wave flattening or T-wave inversion. So we'll get an idea about what is this ST depression and T inversion. So this is called isoelectric line. So see this is the P wave, then there is QRS complex, and then T wave. So this line that you see is called isoelectric line. Now this is ST, right? if by any chance ST comes down to this isoelectric line, that becomes ST depression. Horizontal or downsloping ST depression in more than equal to 2 contiguous leads indicate myocardial ischemia. Just a single ST depression is nothing. But when back to back, so contiguous leads, at least 2 of them has got ST depression, then that is significant. But upsloping, so you can see this is the upsloping ST depression, that is not significant. So either the horizontal ST depression or the downsloping ST depression, that is significant. And you can see that this is the isoelectric line. Okay, so always remember that ST depression, if it is more than equal to 2 contiguous leads, then that will be significant. Otherwise, no need to even think about anything. So significance of ST depression is that there is a likely chance that patient having either an unstable angina or non-ST elevated AMI. So you'll need to do a troponin in this case. How about T-wave inversion? So again, for T-wave inversion to become significant, at least 2 continuous lead should have that, and at least 1 millimeter deep. 1 millimeter deep means at least 1 small square should be there. What do I mean by that is that if we look over here, what we see, it's a bit smaller for you to understand, I guess. So V1 to V6. So V1, V2, V3, V4, V5, V6, these are chest leads. And then you have got lead 1, lead 2, lead 3, AVR, AVL, AVF. These are called limb leads. For anyone having chest pain, we first look at V1 to V6. So in the V1, the T wave is not inverted, right? V2 T wave is good. V3 T wave is good. And then V4. Now, if you look over here, you can see the T wave is a bit inverted like this. Definitely this one, V5 and V6. So that is what we call as T inversion. Now, that is significant because definitely it is more than 1 smaller square and it is like continuous leads. So when you get something like that, then there is a chance that this patient has got a non-ST elevated acute coronary syndrome. Could be just a angina, could be MI as well. So you need to do further investigation to know about it. Now, the next one is ST elevated MI. For ST elevated MI, the name says what you are going to get in here. So ST elevation. So that's what is your finding that you want to look for. So patient with ST elevated MI will present to us with sudden onset of chest pain, which will look like a cardiac chest pain. Then you look at V1 to V6 first. And if we look over here, what we see, so V1, this is the isoelectric line, not that much of ST elevation, but there is definitely T inversion. But if you look at V2, you can see that this is isoelectric line and ST wave is definitely, it is elevated. So there is ST elevation, V4 has got ST elevation, V5 has got ST elevation, V6 not that much. So definitely V2, V3, V4, they have got the main ST elevation. So you have found ST elevation in anterior leads. Then you look at lead 1 and lead AVL because these are usually interconnected. So these are called high lateral leads. So if you look over here, this one has got ST depression. AVL has got ST depression. So it's not very, very important. So that's fine. And then we look at inferior lead, which is lead 2, 3, and AVF. Lead 2, 3, AVF, these are normal. So this is what we will call as anterior MI, or even V2, V3, V4 is called septal MI. You don't need to know what kind of MI it is for exam. As long as you know what is like how to detect myocardial infarction, you are good. Okay, so that is ST elevated MI. Is there any problem or confusion with understanding ST elevated MI, guys? All clear? Oh, good. Let's have a look to another ST elevation. So this patient has come to you with chest pain. So you look at the V1. So V1, bit of ST elevation, but V2 is definitely there is ST elevation. The elevation point over here is called J point. Okay, so this is called J point, which is ST elevation. Then there is V3, ST elevation, V4, ST elevation, V5, V6, not much. V1, then lead 1. Lead 1 has got ST elevation. Lead 2 has got ST elevation, just a bit. So lead 1 and AVL also has got it, but lead 2, 3 AVF, nothing much of a change. So this is also what we will call as anterolateral MI. So anterior lead has got ST elevation and lateral lead has got ST elevation. So anterolateral MI. So criteria of ST elevation is that like definitely isoelectric line is the main thing. So if you see that if the ST is above the isoelectric line and it is more than 1 smallest square at least, that will be regarded as ST elevation. And Dr. Vindhya, what about lead 1 and AVL? Which one? This one? So you have seen the anterior MI, but let's see how the inferior MI will look like. So if you look over here, so again we look at V1 to V6. So in the V1, it's fine. V2, no ST elevation. V3, V4, V5, V6. So there is no ST elevation in anterior lead. Let's look at lead 1 and AVL. That's also quite normal. AVL has got bit of a ST depression, but just a single lead, so it's not pathognomic. So that's okay. Lead 2. Lead 2 has got ST elevation. Lead 3 has got ST elevation. Lead AVF has got ST elevation. So that's inferior MI. Now you might have understood the pattern that if there is a connection between anterior lead and inferior lead. We say that if there is ST elevation in anterior leads, then inferior lead should be either normal or there might be a ST depression, not ST elevation. So this is called reciprocal changes. So if ST elevation in anterior leads, then either inferior lead will be just totally normal or they might have a reciprocal ST depression. And that is very important finding. The other one is that if there is ST elevation in inferior lead, like this one, there might be either normal or depression of like either normal or ST depression in anterolateral leads. And this AVL, this depression that you see over here, that might be the reciprocal ST depression. So it just confirms that it is myocardial infarction, it is not pericarditis. In pericarditis, anterior lead, lateral lead, inferior lead, every lead will have ST elevation. But in MI, there is a bit of reciprocal changes. That's how we can easily differentiate between these two. Okay. So there comes your pericarditis as we are discussing. So pericarditis is defined as a global ST elevation in almost all leads in the ECG. You might not get every lead, but almost all leads will have a ST elevation. How so? Let's have a look. So V1, so now sometimes in pericarditis you can get a ST depression in lead AVR and V1, so that's fine. So V1 has got ST depression, but V2, so if you look over here, V2 has got a bit of ST elevation, definitely V3. V4 has got ST elevation, V5, V6. Let's see lead 1. Lead 1 just a little bit. Lead 2 is no ST elevation. Like lead AVL is no ST elevation. Looking at lead 2 has got ST elevation. 3 has got ST elevation. AVF has got ST elevation. Now you have got ST elevation in anterior lead, lateral lead, and inferior lead. When there is a global ST elevation like this, that's the time you would think of pericarditis. Okay? So sometimes also it is easier to diagnose the pericarditis ST elevation, that it's kind of a concavity upward like this, as if like you can just sit on this ST elevation. Okay? So this kind of concavity upward ST elevation is common in pericarditis. Making sense for everyone? Any confusion? So this one, Dr. Vindhya, lead 1 and AVL, right? So lead 1, this is the isoelectric line. So you can see a bit of ST depression, and lead AVL is fine. Not much of a change in here. Same extensive MI means that there will be ST elevation in all the anterior lead and lead 1 and AVL. When there is a ST elevation in lead V1 to V6 and lead 1 and AVL, that's extensive MI. But still inferior leads will not have ST elevation. But in pericarditis, inferior lead will also have ST elevation. That's how you differentiate. Okay, now few more ECG, which is not very commonly asked, but we were going to discuss that. So hyperkalemia is very important for the exam. I need you guys to read hyperkalemia guideline from RSCGP. So if you hyperkalemia RCH, RSCGP. So in here, there is some discussion about hyperkalemia. Hyperkalemia means when potassium level is more than 5.5. If a patient develops hyperkalemia, you'll have to stop any medication which can increase potassium, like ACE inhibitors, NSAIDs, okay, spironolactone. So if a patient has got hyperkalemia, then this medication should be stopped. Then you look at few things. If this patient unstable or symptomatic, or there is some abnormal ECG pattern, or potassium more than 7, any of this is there, that patient will need a calcium gluconate. So IV calcium gluconate is the first choice. So any hyperkalemia patient has got ECG changes, the first treatment is calcium gluconate. Very, very important case for exam. After that, we can try any of these: salbutamol nebulizer, insulin plus glucose IV infusion, bicarbonate, or even Rezonia. But any hyperkalemia, whatever is the level, but if there is a ECG change, that patient require a IV calcium gluconate or IV calcium chloride. So you can see that you have to give either a calcium gluconate 10% or a calcium chloride 10%. So this is the choice of treatment for ECG changes with hyperkalemia. If patient is asymptomatic, normal ECG and potassium between 6 to 7, then no need of calcium IV gluconate. You can give any of the others to reduce the potassium. Patient asymptomatic, normal ECG, potassium less than 6, then usually no treatment is needed. You can just review the patient, stop any offending drug, and repeat the blood test to see that if the potassium is coming down. Okay? So go through this guideline a little bit to know about this. So what is the hyperkalemia ECG finding? Sometimes even they ask you in the question that which one of the following is the ECG finding for hypokalemia or hyperkalemia. So you should remember it. Hyperkalemia will give you prolonged PR interval, but most importantly, a tall peaked T wave. And you can get a broad bizarre QRS complex. So let's see how it looks like. So in hyperkalemia, the T wave will be abnormally tall, and it's very evident by looking at the ECG. So if you look over here, you can see how tall is the T wave, right? So this kind of tall peaked T wave is the main finding of hyperkalemia. Other than that, you can see the QRS complex is very broad. So that's also another finding. So tall peaked T wave and broad QRS complex, that's our main finding. If you get this finding, then that patient will require calcium gluconate. Okay. Hypokalemia doesn't come in exam, so I'm not quite bothered about that. QT prolongation. Prolonged QT interval is important. So we know that normal QT is between 8 to 11 small square. If it is more than 11 small square, then it is QT prolongation. And these are all the causes. So any hypokalemia, magnesemia, so any of the hypoelectrolytes can cause it. Have a look how to detect QT interval. So this kind of patient usually comes to you with, like, maybe sometimes they can get dizzy, lightheaded, or even a syncopal attack. Then you do the ECG. ECG will look totally normal. Nothing you can find out. Then you should look at the long lead. And in the long lead, you can see that the rhythm is regular, right? There is P wave followed by QRS, then T wave. So everything looks normal. So why this patient having problem? Then you check the QT interval. So Q is starting of the Q wave and finishing of the T wave, right? So measure the number of small square. So 5, 10, 15, 16. So at least 16 small square in here. So we know that up to 11 is normal. More than 11 means it is a prolonged QT syndrome. So this patient has got prolonged QT syndrome. So you'll need to find out what's causing this. If there is any electrolyte abnormality, if the patient is taking any antibiotic which can cause it, any medication can cause it. So find out the cause and treat it. And for QT prolongation, if we can't find out any cause and patient is symptomatic, we can give them beta blocker to reduce the feeling of like arrhythmia or palpitation or even dizziness. Not very important, hypercalcemia. So hypercalcemia, the only way to remember it is, see this notch over here. So all this notch that you see is called Osborne wave. Hypercalcemia patient can have this Osborne wave, which you will not get in a normal QRS. Normal QRS is like this. But when you get this kind of a notch, then it is Osborne wave, which you can get in hypercalcemia patient. Not important, just you can remember it. Digoxin toxicity. So digoxin toxicity, I remember we talked about the reverse tick sign a little bit in our question solve class. So ST depression with a reverse tick sign is the main feature of digoxin toxicity in ECG. But toxicity can give you almost any kind of arrhythmia or heart block. So patient can get anything. So any kind of heart block, they can give you ventricular bigeminy or trigeminy, which is the PVC, which is premature ventricular complex. So let's have a look to the reverse tick sign. So patient on digoxin, if you have done a ECG, and you can see that there is a downsloping ST depression, and then this is the reverse tick sign. Okay, so when you get this kind of reverse tick, that's what you get in a digoxin toxicity patient. The other than that, you can get PVC, which is premature ventricular complex. Very common in elderly patient. PVC can be divided into ventricular bigeminy or trigeminy. So what is bigeminy? Bigeminy means that there is a normal PQRS complex followed by an abnormal one. You can see that this is definitely abnormal. The QRS is broad. There is no P wave. So then there is an abnormal one. Then there is normal followed by another abnormal. So when one normal QRS complex, it's followed by another abnormal QRS complex, and that goes on and on. That's bigeminy. Okay. What is trigeminy? Trigeminy means that there is one normal QRS, another normal QRS, and then there is a abnormal bigeminy or abnormal QRS complex. So two normal followed by an abnormal is trigeminy. So one normal followed by one abnormal, that's bigeminy. Two normal followed by one abnormal is trigeminy. So this is what we call as PVC, which you can find in a digoxin toxicity patient, and sometimes even in a normal patient as well. Okay. So you can see on this ECG, if we look at the long lead, you can see this is a normal QRS complex, and then there is the abnormal one. Normal, abnormal, normal, abnormal. So that's what we will call as bigeminy. Is it making sense for everyone? Yeah, good. Okay, left ventricular hypertrophy, ECG. So it's not very important, but you can definitely know. So left ventricular hypertrophy means that we take the S wave in V1 and R wave in V5 or V6. And if it is more than 35 millimeter, that's left ventricular hypertrophy. Let's see what I mean by that. So S wave in V1. So this is V1, and we can see that's the R and that's the S, right? So how much S wave, so like how deep is the S wave? So there's one largest square, two largest square, three, four largest square, which means 4 into 5 equal to 20. So 20 is smallest square. So it is 20 millimeter plus what is the length of R wave in V5 or V6? So let's say V6. So we have got one largest square, 2, 3, 4, 5. So 5 largest square equal to 25. So 45 millimeter, right? We know that if this is above 35 millimeter, that's left ventricular hypertrophy. So this one is definitely having a left ventricular hypertrophy. The commonest cause of LVS is hypertension. So that's LVS. Then pulmonary embolism ECG finding. Now, pulmonary embolism, the most common ECG finding is sinus tachycardia. That means you just get sinus tachycardia, nothing else. So then we can get in this patient is called S1 Q3 T3 pattern. This is a rarely you will ever get it, but if you get it, you can think that this is pulmonary embolism. So deep S in lead 1, that's why it's called S1, Q wave in lead 3, an inversion of T wave in lead 3. Let's have a look how it looks like. So deep S in lead 1. So this is lead 1. You can see this is the R wave and this is the S wave. So S wave is definitely deep, then R. So that's your S1. Q3. So lead 3 will have a Q wave. Lead 3, you've got a Q wave. Usually you don't get Q wave because having a Q wave indicates old myocardial infarction. So normally you don't get Q wave in anywhere. But in pulmonary embolism, you can get this Q wave. Q3, then T3. So lead 3 will have a T inversion. So you can see a T inversion in lead 3 also. So that is what we call as S1. So deep S in lead 1, Q wave in lead 3, and T inversion in lead 3. So S1, Q3, T3, that is a finding of pulmonary embolism. Okay, but it will rarely come in your exam, so don't get too much confused about it. Left ventricular hypertrophy, Dr. Suraya. So you check how deep is the S wave in V1. So you can see that this is the deep. This is how deep is the S wave. So there are 1, 2, 3, 4 large square. 4 large square will have 4 large square into 5. So equal to 20 small square. And then you have got V6. You check the R wave, how deep it is. So you have got 1, 2, 3, 4, 5. So 5 large square in V6. So 5 into 5, 25. So 45. So 45 is your like V1 and V6 length of S wave and R wave. If it is more than 35, that's LVH. So you have got 45. So that is why we know it is left ventricular hypertrophy. Clear? So how we recognize Q wave? The first downward movement before QRS complex. So this is P wave. The first downward wave before R wave is Q wave. And then after R wave, the second downward is S wave. So first downslope before R wave is Q wave. And then after R wave, the downslope is S wave. That's how we know. Okay, making sense? Any kind of Q wave is pathological. Okay, especially if it is more than 1 millimeter deep, that is pathological. So normally we don't get Q wave in any patient. Okay, so right axis and left axis deviation, and that's where we will finish today. So right axis deviation, it's going to come in your exam, but it's a good to know. So you look at lead 1 and you look at lead 3. The easiest way to remember is that if lead 1 is looking towards the lead 3, so you can see that lead 1 is looking towards the lead 3. So when lead 1 looks towards the lead 3, that's right axis deviation, which is not normal. And when lead 1 looks away from lead 3, so you can see lead 1 is looking towards this side and lead 3 is looking towards this side. So when they look away from each other, that's left axis deviation. Okay? So that's right and left axis deviation, not important to know, but it's good to know. Okay? So that's all about your ECG. This is a lot, right? It's a lot to know, but I hope it made some kind of sense. And it is difficult with just one discussion like this. I would advise you tomorrow morning, you go through the recordings. If we might not be able to just like upload that by tomorrow morning, but By tomorrow at night, if it is getting uploaded, just make sure you review the recording again, go through the class again, and definitely it will make a lot of sense. The first time you have learned, you're just getting the basic. Second time when you listen, you will get the whole of it. Okay, that's how usually you can get a very good idea of this ECG. We'll just do few things. So let's see if we can remember what we have discussed. So this is a ECG to you, and patient came to you with palpitation. What's your diagnosis? So definitely, right? So you can even recognize by the flutter waves. So that's sawtooth appearance. So that's atrial flutter. See that now you will be really good. I can already getting the sense of it. Let's see the second one. Let's do this one. So what do you think this patient has got? VT, definitely, right? So ventricular tachycardia, most likely monomorphic VT. So you can see that these are all regularly spaced white QRS complex. So VT. What about this one? Is it SVT? Because there is no, like, you can't see any kind of, like, it's not a narrow QRS complex, right? This is also kind of a VT. Okay, it's a bit like the pulse rate will be a little bit better, but it is also a VT. It is white complex tachycardia, but in a SVT patient, the QRS complex should be narrow. Bit hard, it's understandable. What about this one? Let's see if you can get this. Patient came to you with palpitation. This is sinus tachycardia, guys. So you can see that there is tachycardia. Rate is definitely elevated, but it's not SVT because you can see the P wave. When there is P wave, it becomes sinus tachycardia. If this P wave is not here, this would become SVT. Okay. What about this one? Check the lead 2. So we can see that if you look over here, there is a drop beat here. There is a drop beat here. So when there is a drop beat, it is type 2 heart block. Find out if it is a, like, it's a second degree heart block. Is it a Mobis type 1 or type 2? So then check the PR interval. So this is PR. Then there is, this is PR. That's PR. So it is getting a little bit increased every time we are doing the PR interval, right? So it's getting increased, followed by a drop beat. So it is type 1 or type 2? Type 1 will be gradually increasing. So that is type 1, not type 2. Type 2 will have a constant PR interval. Okay, very good. So you're definitely, you understood what we discussed today. So that's very good. Okay, so that's all that we wanted to discuss today. Okay. Okay, Dr. Shaba. What's the difference between AF and VF? After the ECG class, that's what we are asking. That's not good. There is a lot of difference is there. look at the chaos. So you can't see anything else rather than just QRS complex, right? So all you can see is QRS complex, and they are like chaotic rhythm. And if you look on the AF, is it chaos? There is no chaos, okay? But there is all you can see, there is QRS complex, which is bit of narrow QRS complex. And then you can see this fibrillatory F waves, okay? But definitely in VF, the QRS complex will be much wider, but F usually narrow. Okay. All right. So that's it for tonight, guys. I hope you learned few things today. I hope it was interesting, not boring. But try to remember everything, because that's the hardest part. Because most of the people, they just forget about what I said after the class. The important ones are SVT, atrial flutter, atrial fibrillation, VT-VF, heart block, and myocardial infarction, and hyperkalemia. These are the most important ones. So you should remember these at least. We don't look at QRS complex for heart block. It doesn't give us that much of information, Dr. Nancy. Most of the time we can get it like a bit of like wider one, not narrow. So important ones are SVT, flutter fibrillation, WPW syndrome, VTVF. Then we have got heart block and MI and hyperkalemia. All right, guys, so we'll stop it here tonight. Thank you all for joining the session. Very good. Well done. Take care.